Well, greetings, everyone, and welcome to the EKG case for the week of November 18th, 2013. This week's case was sent all the way from the West Coast of the United States by Dr. Justin Cook, and I'll try to get all of his titles right. Justin is actually a guy that I work with, a real class act of a person, and he is co-faculty at a critical care conference that I have the privilege of speaking at. Justin is Director of Emergency Ultrasound in the Department of Emergency Medicine at the Legacy Emmanuel Health Center in Portland, Oregon. He's also a member of the faculty at Highland General Hospital and Alameda County Medical Center in Oakland, California. And probably his most important title is just an all-around super nice guy. And he's really smart also. So great combination for an emergency physician. Anyway, one day he was working and had this 40-year-old woman who presented to the emergency department with, I forget where she was from, but she didn't speak much English, very broken English at all. But to the best that he could figure, she had no past medical history. And she came in with a tenuous blood pressure of systolic 90 to 100 or so. And she had an SVT. Now, I'm not going to kind of skip over some of the details of this case, and because I want to go back into this case another week and talk about everything that happened. But for the purposes of this case, I just want to summarize things and tell you what happened. Justin decided to electrically cardiovert this patient. We'll talk about why another week, but he decided to electrically cardiovert this patient, even though she had what looks like a run-of-the-mill normal SVT. It's regular, it's narrow, complex. Yeah, there's some ST segment depressions, which are very common in SVTs, and they don't really correspond to any critical coronary lesions as long as they resolve after conversion. But because her blood pressure was tenuous, he cardioverted the patient, and after cardioversion, this is what he ended up coming up with. She's back in normal sinus rhythm, and take a look at this. Hit the pause button if you need to. What else is going on here? Well, you hopefully will notice that there's a short PR interval, and there's also delta waves in a lot of the leads here. This patient actually has WPW. Again, she had no known prior medical history, and that means that when she had her SVT, this was probably that orthodromic narrow complex SVT that patients with WPW are predisposed to develop. So this week, we're going to spend a little time talking about SVTs in WPW, and the next week we're going to talk about atrial fibrillation. It's probably been a couple of years, honestly, since we've spent much time talking about WPW's arrhythmias, and so I figure, well, it's time again, and I've got a handful of great cases to share with you. So first of all, let's just do a little background on WPW. Everybody should remember the classic triad for Wolff-Parkinson-White syndrome, which is the most common form of ventricular preexcitation, short PR, wide QRS, slightly wide QRS, and then there is the classic slurred upstroke, which everybody always remembers, the delta wave. I always try to teach that the short PR is really the key, because if you're looking for delta waves, you might have a tendency to undercall and also overcall WPW. You can kind of imagine delta waves in a lot of EKGs, but the short PR has to be there, and so that's really the key. It's not uncommon, especially in emergency department arrhythmia type of populations that we see. So everybody out there is seeing WPW. It's in every ethnic group, I'm sure, and in every country out there. So here's what's happening with normal conduction. With normal conduction, your heart, your SA node, sends an impulse down to the AV node. And as it goes through the atrium, the atrium contracts, and that produces your P wave. That's where the P wave comes from, atrial contraction. Then the impulse goes down through the AV node, and it just kind of meanders through the AV node. No big rush. Nothing is happening when the impulse is going through the AV node, and that is what produces that little flat line that we call the PR segment, or at least that portion of the PR segment. Nothing is happening. It's just a flat isoelectric segment that you're looking at there. Nothing's happening. And then that impulse gets fired very, very rapidly through the His-Purkinje system, which is a very, very efficient form of conduction. It almost virtually simultaneously produces ventricular contraction, and that produces a narrow QRS complex. So that's where your P wave, your PR interval, and your QRS come from with normal conduction. Now, if a person has an accessory pathway up there, what happens is you've got your normal impulse going down through the AV node. You get your atrial beat right there, and then it hits the AV node, and then it just slows down. Nothing's happening. But simultaneously, you've also got this impulse going down through the accessory pathway. Notice that there's no AV node there. So the impulse just hits the ventricle early and starts ventricular contraction early, thus the term pre-excitation. So out here, you start getting myocyte to myocyte contraction of the ventricle, which is a very inefficient form of ventricular contraction. And because it hits the ventricle early, you lose your PR segment, or you end up with a very short PR segment, and you get myocyte to myocyte contraction that slurs the upstroke of the QRS, and then after a few milliseconds or so, the His-Purkinje system sees the impulse and fires the beat through, and it catches up. So the back half of the QRS complex is completely normal because of the His-Purkinje conduction, but the first part of the QRS complex is just a little bit slurred and a little bit wide because you've got this myocyte to myocyte conduction happening right out there. And so that's where your classic triad comes from. The short PR because the ventricle starts contracting early, and then the slurred upstroke and the slightly wide QRS complex. There's your classic triad. Okay, now we're going to talk about SVT this week. We'll talk about atrial fibrillation next week. There's two types of SVT that occur, and I'm going to preface this by simply saying WPW plus SVT is not a big deal. If you know nothing about orthodromic and antidromic SVT, that's okay. You're probably already doing everything right. It's not a big deal. People love to talk about this, but I think probably people talk too much about this because it's a piece of cake. SVT with WPW, piece of cake. All right, and you'll see why. So first, let's talk about orthodromic tachycardia. It sounds fancy. It's really not. What happens with orthodromic tachycardia? Well, with orthodromic SVT, you get an impulse that goes down the His-Purkinje system, and then it uses the accessory pathway as a reentrant limb. Down the accessory pathway, down the normal pathway, up the accessory pathway, down the normal pathway, up the accessory pathway, and it spirals around very, very, very rapidly in an electrical circuit. And notice that because you're innervating the ventricle through the His-Purkinje system, your QRS complexes are narrow. These are nice, normal, narrow complexes. So what you end up with is a regular narrow complex tachycardia. NCT, narrow complex tachycardia. And so when you see this is what you're going to see. That's what Dr. Cook saw. All right, it's a narrow complex tachycardia, and it looks just like any other SVT you've ever seen before in your life. So you're going to look at this and you're going to say, no big deal. This is just a plain old SVT. So you can try vagal maneuvers, you can try adenosine, calcium channel blockers, beta blockers. Pretty much anything you use is going to work very nicely, because if you remember what all of those things are, those are all forms of AV nodal blockade. And what they do is they block the AV node. They cut the circuit at the AV node. So this electrical impulse suddenly gets cut. And if you remember, anytime you cut a circuit anywhere, it breaks the circuit and you end up converting the patient. So any AV nodal blocker is perfectly safe with this type of SVT. So then the patient converts to this, normal sinus. You get a 12 lead. Now you see the delta waves and the short PR, and you say, oh my gosh, this is WPW. Oh, that must have been that orthodromic SVT. It's narrow, it's regular. This patient's got WPW, and that must have been the orthodromic SVT. But you know what? Everything that you did worked out perfectly. When you looked at this thing, you thought this is just an SVT, and every normal intervention you do for SVT works perfectly. So orthodromic SVT, just treat it just like any other SVT and you're golden. It works beautifully. That's why orthodromic SVT is really not a big deal. What about antidromic SVT? People get a bit more anxious about this for no good reason, and here's why. With antidromic SVT, with WPW, the impulse travels down the accessory pathway, and it uses the normal pathway as the reentrant limb. Down the accessory pathway, up the normal pathway, down the accessory, up the normal pathway. And it spirals around very, very rapidly. I'm kind of making a mess here, but this spirals around very, very rapidly, once again, in an electrical circuit. Okay, so it's regular once again. Because it's hitting the ventricle out here through the accessory pathway, what happens is the ventricle contracts myocyte to myocyte, which is very inefficient, and that means that you have a wide QRS complex. So what you end up with is a regular wide complex tachycardia. Okay, this electrical circuit produces a regular wide complex tachycardia. So when you get this 12-lead EKG, what's it going to look like? It's going to look like any other ventricular tachycardia that you've ever seen. And here's a 12-lead EKG that was provided by one of my outstanding residents, Dr. Phil Magidson, and he was taking care of a patient that had an antidromic SVT with WPW. And take a look, it looks just like VTach. In fact, sometimes you can even get fusion beats or capture beats. There's no good, reliable way that's ever been produced or published of telling the difference between the antidromic SVT of WPW versus VTach. There's no good way of telling the difference. So when you get this 12-lead EKG, you see a regular wide complex tachycardia, what are you going to be thinking? Hopefully, if you're smart, you're going to be thinking, oh my gosh, I've got a patient with ventricular tachycardia. All right? And so what are you going to do for ventricular tachycardia? Well, there's a couple of things that you can do. You can give the patient procainamide. I love procainamide. Procainamide preferentially suppresses the accessory pathway, and it works beautifully. You can use amiodarone, which will help suppress the accessory pathway. It also works as an AV nodal blocker. Amiodarone is part calcium channel blocker, part beta blocker. It cuts the circuit at the AV node. And remember, anytime you break a circuit anywhere along the circuit, you'll convert it. And so amiodarone will work. If you choose procainamide, that works. Amiodarone works. Lidocaine won't work. It won't hurt, though. So if you tried lidocaine, you're just going to need to move on because it's not going to do anything. You can even shock this patient. Shocking works quickly, nicely. It's kind of fun. So if you want to shock these patients, that works perfectly also. So the key thing here to say about antidromic SVT is that if you mistakenly call this VTach, and I hope you do, and you treat this patient for VTach, everything you normally do for VTach works perfectly. And what you end up finding is that it converts the patient back to sinus rhythm. So you're going to look at this thing, you're going to say, oh my gosh, I've got VTach. You give them amio, procainamide, you shock them, you convert them to this. They're in sinus rhythm with WPW, right? Delta wave, short PR. And you're going to say, oh, that must have been that antidromic SVT that I was taking care of. But you know what? Everything that you did worked perfectly. So that's why I say, if you have the orthodromic SVT, you're going to see a narrow regular tachycardia and treat it just like any other normal SVT you've ever seen, and it works perfectly. Boom, no problem. If you have an antidromic SVT, you're going to mistakenly call this VTach, which is good because all of the stuff you normally do for VTach pretty much works perfectly also. So that's why I say that if you have orthodromic or antidromic tachycardia with SVT, just treat it like you normally treat narrow SVT or VTach. And that's why it's really not a big deal. SVT with WPW, not a big deal. I hope that's clear. What is a big deal is atrial fibrillation with WPW, and that's what we're going to talk about next week. And the reason we need to talk about that is that this is not a circuit. This is not an electrical circuit, and that means this is very, very different. This also means, as you'll see next week, as we talked about a couple years ago, The way that you treat these patients is critical, because if you don't treat these patients, AFib patients, if you don't treat them properly, you kill them. You kill them very, very quickly and efficiently. Not a good thing. All right, so quick take-home points about WPW with SVT. It's not a big deal. If it's orthodromic, you're going to see a narrow regular tachycardia. Treat it just like any other SVT you've ever seen before, and it works beautifully. If you have the antidromic SVT, it's going to be wide and regular. You're going to think you're looking at VTAC. Go ahead and treat it just like VTAC. Lidocaine won't work, but amio and procainamide probably will work, or if you shock them, that'll work also. So just call it VTAC and be done with it, and you will treat them perfectly fine as well. All right, so that's it for this week. Before I sign off, I just wanted to send out a reminder. The Resuscitation 2014 conference is coming up. It's in Las Vegas, Nevada, March 28th through the 31st. There's the website, www.resuscitation-conference.com. And the reason why I'm letting you know about this is that if you want to learn more about arrhythmias, I'm going to be doing a dysrhythmia workshop for about 3 hours or so. We're going to cover a lot of tough dysrhythmias, many of which we've talked about in this series. The title of the workshop is Dysrhythmias to Die For. And again, we'll talk about deadly dysrhythmias. We're going to have some fun with that. I hope to see many of you in Las Vegas. Remember, www.resuscitation-conference.com. It's a great, great conference. Check out that website, and hopefully I'll see some of you there. Hope this was helpful. Next week, we'll talk about atrial fibrillation with WPW. And until then, take care.
Hey everybody, welcome back for another installment of the Emergency Ultrasound Nerve Block Project. I'm Mike Stone.
And this is Arun Nagdev.
And we are going to talk about a cool case. This was a 30-ish-year-old guy, walked downstairs and tripped, fallen down about 12 or 13 stairs, and came in with hand pain, kind of classic boxer's fracture, but in this case wasn't punching somebody, actually just fell down the stairs. So Arun, when you have patients with boxer's fractures, how do you usually manage them?
Yeah, so I think you have two options. You have either a local infiltration or a hematoma block, or what we commonly do at Highland, which is an ulnar nerve block. So what happened with this guy, Mike?
So we went ahead and consented him, put a high-frequency linear probe midway up the forearm, tracked up the arm until the ulnar artery and the ulnar nerve split apart. So you had a little extra margin of safety without the ulnar artery right there. So our intern did a great job. Used about 5 or 7 cc's, although once you have some experience, you can do this with as little as probably 2 to 4 cc's of local anesthetic. We used plain bupivacaine, 0.5% without epinephrine. And in this case, we just got all the splinting material together and got all that stuff set. Came back, went ahead and did a closed reduction on him. Actually used ultrasound to verify the adequacy of the reduction as we were
Very
going.
nice.
And I think I got a couple of images of that I can put up. And then splinted him, had a nice alignment, and followed up electively with orthopedics for just casting and no further operative intervention.
So nice, using this to facilitate something that would have been maybe more difficult, and also before you get the x-ray to make sure there's a good alignment. Very nice.
Cool. All right, well, next time, everybody take care.
Take care.